Hello, everyone. This is Sharon Ng. I am a Master's of Arts counseling student at Yorkville University. At the time of doing this video, I am still a student and about to go into my practicum. I thought I'd share some PowerPoint slides that I created based on my elective course on crisis and trauma counseling. Specifically, I did an overview of cognitive processing therapy. I do want to create a disclosure here that I am not offering any counseling or expertise advice here. This is merely an overview of the trauma literature. So with that being said, I hope this is helpful to any students or existing counselors or people that are thinking about getting into cognitive processing therapy that they could perhaps discuss with their counselor or health professional. So a bit of CPT, that's short for cognitive processing therapy. A bit of the background information on it is that it is a trauma treatment for any trauma-related treatment, such as post-traumatic stress disorder or acute stress disorder. CPT's effectiveness in reducing PTSD's outcome extending to psychosocial domains has been strongly supported by current trauma literature. Researchers have found that CPT improved PTSD adjustments, such as in social and leisure life, and it lasted longer than those being treated with more prolonged exposure therapy, which is another evidence-based therapy for trauma treatment. Other researchers also echoed similar findings in CPT's effectiveness to reduce PTSD symptoms such as numbing and avoidance, which are often associated with PTSD adjustments shortly after treatment. However, other markers of effectiveness, such as attrition and/or dropout rates, should be considered. Researchers have also found that despite CPT's reduced PTSD symptoms more effectively than individual person-centered therapy, CPT treatment group experienced higher dropout rates, though. So at the time of making this webinar, there still needs to be more research into the effectiveness of group therapy for CPT. CPT's highly structured modality allows for direct training for its components to minimize clinician variability. For instance, different clinicians may have different levels of competency. If they are a master's counselor or PhD counselor, it should not matter that it could otherwise confound with treatment outcomes. For instance, Resick and Monson found that regardless of the clinician's competency level in delivering CPT, this doesn't affect the overall improvement of PTSD symptoms. Further, CPT's structured components have been applicable cross-culturally and translated to at least 12 different languages. Resick and Monson also claims that CPT theory and concepts are universally understood and have not lost treatment integrity through translating across different languages. So a bit of the theoretical perspective behind CPT are that it's premised on viewing the PTSD survivor's potential to constructively explore past trauma through answering Socratic questions that can mobilize them to seek answers for themselves. The stepping back of CPT clinicians to allow survivors to self-discover answers of past trauma can empower them to internalize changes in the face of PTSD, thereby reducing the effects of associated symptoms. Specifically, the clinician guides the survivor to rework trauma-related assumptions and perceptions through activating memories, thoughts, and feelings that occurred at the time of trauma events. The act of recalling and/or describing these trauma thoughts can trigger dual processes of event-related attributions and emotional activation for the survivor. The emotional activation is the exposure portion of CPT that allows the survivor to relive the trauma event. Such activation helps the survivor confront unprocessed memories and inaccurate thoughts or stuck points that linger within them as associated emotions remain preserved to the time the trauma event took place. The survivor is then guided to rationalize past these stuck points repetitively enough to allow opportunities for simulating new schematic realities. A coherent story can then be formulated as the survivor reframes new meaning behind their trauma experiences hitherto. Hopefully, this time a more adaptable story. The theoretical perspective foregrounding CPT's techniques are based on the biological model of the reciprocal relationship between the amygdala, or fear response center, and prefrontal cortex, in other words, fear response director. When one responds to trauma, their amygdala becomes activated as the prefrontal cortex continues to direct resources there and reduces its overall functioning in other bodily parts and processes. Specifically, the prefrontal cortex's capacity for containing higher executive processing, such as processing trauma memory, is disrupted, and thereby some memories may or may not be stored at cognitive levels. The paradoxical consequences of prolonged trauma exposure reduces the functioning of the survivor's prefrontal cortex and eventually the size, thereby making them more oblivious and susceptible to subsequent trauma. CPT opts to target this fear response structure during exposure by having the survivor re-experience the trauma, this time in the safe confines of a therapeutic environment. Resick and Monson would describe this re-experiencing of past trauma as potential for the survivor to assimilate or develop new schematic understanding that is more adaptive frame of reference in informing survivors' past and current realities. Moving into the intervention strategy of CPT is an outline. At the start of any trauma intervention, we begin with development of therapeutic rapport and support. This is no different of a priority for CPT. Especially with CPT and any cognitive therapies that utilizes exposure techniques, this activation process can inevitably draw out intensely uncomfortable and distressing feelings for the survivor and should take place in context of support and safety. Once a level of therapeutic relationship is established, the clinician will perform a clinical interview to screen for treatment eligibility based on the survivor's safety risk, psychological stability, and readiness for treatment. The interviewer should also inform clinicians of survivor variables, such as their treatment history, trauma nature, such as sexual abuse or physical abuse, and time lapsed since trauma event to determine delivery format, such as group, hybrid, or individual therapy. If the clinician discerns any salient areas of concern that may disrupt treatment, such as having psychosis, subsequent psychometric testing should follow to confirm if an alternate course of action is appropriate for the survivor. The clinician's understanding of the survivor's symptomology and life stability can be drawn from the results from the clinician-administered PTSD scale for DSM, or CAPS-5, to determine if CPT treatment is appropriate for them. Once clinician completes the interview and determines survivors is stable and safe, treatment can begin.